Good morning. I'm Sandy Loveless. I work at Memorial Hospital, and I ran our home health department for many, many years. And about 10 years ago, I decided to make a career change and to get our Memorial primary care providers ready for value-based care. So at that time, I came from an environment where you just talked to patients all day and told them A through Z, how to manage a disease. Do this, do this, do this, do this, do this. And one thing that I know for chronic illness is we're just inundated with information, but information alone does not change behavior, right? If it did, the first time your provider told you that you were overweight, you would immediately probably lose weight, or all of us would probably do that. So that's not the case. So anyway, I have RNs, medical social workers, a physical therapist, LCSWs, and medical assistants working on our team. We are embedded into the physician practice to help them with those patients that are chronically ill. And we have seen that this study, this style of work that we do called motivational interviewing is really impacting our patients with chronic illness. Mostly diabetes management, hypertension management, BMI reduction. That's where we're really seeing some great outcomes. So I want to just talk a little bit about behavioral health. When I started this work, we learned that motivational interviewing, this style, this way you talk to a patient and interview them, came from more of a mental health background. But what we've learned is by taking that approach, it really improves patients with chronic illnesses and how to self-manage their disease. So behavioral health is how do we respond to the situation? So my friend's here with me, Lisa, my coworker. She has 2 PhDs, and as you see, I don't have any of that. I always like to look at Lisa and go like, hey, Lisa, why does one person get so stressed out, their cup is so overflowing with stress, and then the next person, which seems to be doing the same thing in life, having the same condition, the same diagnosis, they seem to be dealing with it pretty well? Well, we know it's our behavioral health. So we want to address challenges with our patients, and that's kind of been our approach. We sit down with the patient. We tell them how long we're going to speak. I am definitely a person that stays on a clock, and I'm moving, and we're moving. We cover about 60,000 lives with about 25 employees, so we've got to be very attentive to what time we have. But we always talk to our patient, and you do too, I know, that they're the expert, not us. They are the expert in their story, and every patient has a story. What's influenced them. As we're talking to that patient, the whole goal here is to improve their own engagement and management of their own chronic condition. So patient engagement is critical, which leads to self-management. And we all know self-management for a chronic illness is how well are we managing our symptoms and following the treatment? How is it affecting what we're doing day to day? I like to think of it like this, really simple. Behavioral health, I'm going to drink 4 glasses of water. I'm going to walk 30 minutes a day a few times a week. Clinical outcome, potentially. Improvement in A1C. Lower BMI. Feeling better, being more healthy. So it's all connected. Something I want to talk about that might be a little different than others is addressing the challenges. We also call that social determinants of health. In the last 10 years of running this department, and partnering with insurance companies to do value-based care. One of the things that I love more than anything is to sit down with the patient and say, tell me what's going on. I do not believe patients wake up and say, I think I'm going to be a failure. I think I will let my diabetes get the best of me because I just really want an amputation of the toe. No, we don't do that. Neither does the patient. So when we sit down, we talk about what is it? What's the barrier for you following the care plan that your physician just ordered? And oftentimes, that's just the breakaway that the patient shares with us. And then we also look at solutions. I like to ask the patient if I can share solutions. I don't want to just take it for granted that they're ready for me to whip out my piece of paper and tell them everything that's available in the community. I want to say, what's worked for you in the past? Is it okay if I share some things that my patients seem to benefit from? And then next, after they agree to that, we're going to set some goals. And those goals need to be shared decision-making goals. So, simple goals, SMART goals, like we all learned probably a long time ago. And then the next step is, how ready are they? How ready are they to make that change? And so what I like to use when I'm talking to my patient is to say, there's a ruler, 0 to 10. Based on what we talked about today, and we could just say something really simple right now, losing weight. My favorite subject since I became over 55. It's a daily journey, isn't it? So I say, after I've coached that patient, hey, I have some things that seem to work for other patients. It's called Carbs Made Simple. Would you like more information? Yes or no, patient? Okay. So we go through the education, we talk about it, and then at the end I say, well, how ready are you to start this new journey? 0 to 10. Patient tells me 5, for example. And I'll always flip it to the positive and say, well, you're a 5. You're not a 2 today. Tell me why you're a 5 and not a 2. Focusing on the positive, not the negative of that patient. Or I might even say, how confident are you that you will start this new plan? So as we run through that with the patient, motivational interviewing, I just want to speak for just a moment about what might be different today, because, gosh, I looked at the agenda and I thought, why in the world am I here to tell you about a department I started 10 years ago? And the only thing I thought I might have different is motivational interviewing. So 10 years ago, we started meeting with our patients and talking to them in such a way that wasn't about asking yes/no questions. We ask open-ended questions. Tell me about this. Tell me more about it. What's worked in the past? And then as the patient's answering that question, and I am being mindful of the clock the whole time. We don't have all day either, just like you don't have all day. So I always tell them in the beginning, this is going to be about a 15 to 30-minute session, and I want to cover a couple of things. And then our takeaway is we're going to summarize what 1 or 2 things you might do different when you leave. So open-ended questions. Affirm the patient throughout that process. In other words, listen more. Have you ever been in a situation, especially as a new clinician, and you were so busy thinking what you needed to ask next that you didn't even remember what they just told you? Can we be honest? Yeah. Home health nurse, 35 years. 88 questions on the assessment. So we just want to take a pause and really listen, and then what we do is we reflect on what the patient just said. So I've asked the patient a question, and then I restate it. Not in verbatim terms, but I restate what they've just told me, what was their story. And then sometimes I even use a complex reflection that says, you're too busy to exercise, but it's really important to you, because they've just told me every single reason why they can't exercise at all. And then lastly, during the motivational interviewing session, we want to summarize the session with the patient. Summary, we want to organize everything that's been said so it enhances the patient's understanding of the situation. That's my favorite part. The summary really connects the work we all do to what the patient is going to do and what they said to us. It's pulling it all together so the patient really feels said. I know motivational interviewing and the style, for me, and about 35 years of nursing, when I went through this, I thought, my goodness, I have been doing things so wrong. I wanted to do it different. And so even when I'm busy with a lot of contracts, most of the insurance companies now pay my staff to help them improve their clinical outcomes. But part of that work is also managing those HEDIS measures, which are a tricky thing to do, I know. But the fun part of the work is really showing that empathy to the patient and coming into the process non-judgmental. I want to tell you a story real quick, and hopefully I did stay on time. When I first started coaching, I went to a physician champion and I said, I'm Sandy, I'm starting a new program. It's free to you. Oh my gosh, they're like, well, who's going to pay for it? I said, well, the insurance is going to pay for it through a reduction in cost of care and improvement in clinical outcomes. It's called a STAR report. They'll end up paying, but it's going to take us a little while. So give me 100 of your worst, sickest diabetic patients. Just give me 100. Let's get started. So he did. And I know he was being silly because he truly gave me the most challenging 100 patients I've ever met in my life. But I'll never forget. I sat down with those patients and I started coaching them. I started talking about the barriers, getting really into they can't afford their medication. Well, what can I do about that? Medication assistance. You know, there's all kinds of things. But more importantly, I just sat down and said, you went to a 4-hour class for diabetes education 4 years ago. What do you remember about it? You know what they told me? Almost every single one of them. What did they remember? About nothing. So that's what I learned. Quit giving out so much information and take a step back and slow it down. So I may only give 2 ideas that day. And then the next section I may give 1 or 2 ideas. And I started just making it baby steps. I call it baby steps. Early wins. And most of the sessions with the patients were always, I will confess, a very emotional experience, because for the first time in many years they felt like not a failure. Like, I can do this. I have diabetes, but I can control my A1C. This was all started, way before continuous glucose monitoring devices were made so easily available to our patients. So, we were doing old school stuff. Carbohydrates made simple. 45 grams of carb for a woman, 60 for a man, back it off if they had the need for weight loss. But it was simple tools, and they really worked. And so I wanted to share with you, if you haven't had an experience with a health coach or care coordinator, it's really worth the investment. And if you have time, or if you hear people say, well, I can't do this because it takes so much time, I have found motivational interviewing technique does not take any more time than what I used to do, which was sit there and preach to a patient all day, every day. Preach, preach, preach. You got to do this, you got to do this, you got to do this. And this definitely improves self-management. So, thank you.
Hello, my name is Lauren, and I work at Alchemy Med Spa as a nurse practitioner and aesthetic injector. I have been in weight loss management for approximately 8 years now, and I enjoy it so much, helping educate patients and walking them through their weight loss program, whether it's lifestyle changes or just diet education or the use of medications in their journey. I am going to be talking about navigating weight management for prolonged vascular health. We all know obesity has consistently been associated with increased risks of vascular and metabolic disease. Looking at some statistics, more than half of the adults are either obese or overweight in the United States currently. Current estimates show that 1 in 4 ischemic heart disease events are attributable to excess weight, and 80% with coronary heart disease are overweight or obese. Obesity and hypertension are both strongly associated with target organ damage in the vasculature, heart, kidneys, and brain. The vascular endothelium plays a central role in the regulation of arterial tone, inflammation, and thrombosis, Endothelial function is impaired in obesity and represents the earliest stage of clinical atherosclerosis. Abnormalities in endothelial function worsen with increased weight burden owing to several mechanisms associated with excess fat mass, including impaired glucose tolerance, insulin resistance, metabolic dysregulation, and systemic inflammation that play a key role in the evolution and clinical expression of vascular disease. Studies show modest weight loss of 5 to 10% can induce clinically significant improvements in endothelial function and metabolic factors without the need to achieve an ideal BMI. 5% weight loss reduces hypertension and hyperglycemia. 5 to 10% reduction in weight improves lipids and can halt diabetes. 10 to 15% reduction in weight reduces cardiac events, and greater than 15% can reduce cardiovascular mortality. Research has shown weight loss and reducing body mass index improves cardiovascular disease risk factors, lowers blood pressure, blood lipids, blood glucose, insulin resistance, and inflammation. Implementing lifestyle modifications, including diet, reduced sedentariness, and increased physical activity, are ways to achieve patients' weight loss goals. Ideally, following a short-term diet is not beneficial to one's health. Instead, focusing on permanent positive changes will help promote lifelong health and well-being. As we've all have talked about so far, educating patients is key. And I loved how Sandy talked about starting with simple tools and going slow, because patients can get so overwhelmed when it comes to learning just simple things of what foods to eat and what foods not to eat. Here are some tips on how to educate patients, simple ways. Teaching them to eat well and balanced meals, not to skip meals, choosing a variety of foods. And like I said earlier, some of these patients don't even know what foods to even choose to eat. So just simple education can go a long way with patients, and how to also teach them how to fill their plate in simple terms. And also limiting fats and sugars. Being active is very important. It's important to teach people to start slow and gradually increase, and not to just hit the gym 6 days a week. It's overwhelming. And being aware and planning ahead, staying out of the kitchen, keeping foods out of sight that you struggle with, little things like that. What else? Losing weight and changing lifestyle habits is difficult, but research shows the impact on overall health is astounding. And I'm going to end by briefly discussing some currently used medications on the market that can help patients reach their weight loss goals. The one most talked about currently are the GLP-1 medications such as semaglutide and tirzepatide. They're probably, out of the list I'm going to talk about today, probably the more safer medications for most patients. Go back one. These GLP-1 medications are used in the treatment of type 2 diabetes. When used in weight loss, they help reduce appetite, keep you feeling full longer, and helps reduce cravings. Studies found that using these medications and making lifestyle changes, patients lost approximately 33.7 pounds versus the 5.7 pounds in those who didn't use the medication. And then some other medications. Phentermine is been around a long time. It's a controlled substance that stimulates the central nervous system to help reduce appetite and keep you full longer. It is not an ideal choice of medication. It is intended to use short-term use only, and is contraindicated in patients with heart disease, arrhythmias, or high blood pressure. Contrave is a medication made up of naltrexone and ibuprofen. These two medications work together on separate parts of the brain to reduce appetite. And this medication, it can be taken long-term. HCG is a hormone produced during pregnancy. It is not FDA approved. However, it has been used in weight loss treatments for many years. This medication is paired with a very low-calorie diet, making it not an ideal choice either for treatment. in the majority of patients. And it has also been linked to possible increased risk in cancer. So there's lots of options, some better than others. But thank you for your time.
I'm Laura. I'm one of the nurse practitioners at Vic. I primarily work in Jasper and up here at Lifestyle Way. I'm going to talk to you about smoking and PAD. So when our patients smoke, we notice that they have restenosis of their stents, their bypass grafts. They have more risk with a AAA, more stroke risk, a cardiac disease. Smoking actually causes a hypercoagulable state and thickening of the carotid intima. When a patient smokes, the carotid chemoreceptor, which is sensitive to nicotine, causes an enhancement of multiple neurotransmitters, which essentially leads to increased myocardial demands and increased hemodynamics. Smokers have increased platelet activation, increased red blood cell mass, and fibrinogen level, which increases the blood viscosity. This will last for years after the patient stops smoking. They saw with acute MI and sudden cardiac death that there was more thrombosis and less sclerotic disease with smokers. Smoking also causes changes in lipid panel, leading to atherogenesis. The triglycerides will increase, HDL lowers, and oxidized LDL increases. So how do we get our patients to stop smoking? Mainly, we have to offer medications and also talk to them about dual nicotine replacement therapy. They recommend that they use a long-acting patch plus another kind of nicotine replacement therapy. They need counseling along with the medications. 1-800-QUIT-NOW is a good resource. There are many federal and state resources that are free for patients to use. There's special populations we have to consider with nicotine and acute coronary syndrome. If it's nicotine replacement therapy, it is not absorbed as rapidly as smoking nicotine. And there's also no thrombogenesis with nicotine replacement therapy. With bupropion, patients with seizures, it's probably not the medication you want to choose. And there's also some kind of controversy with like Chantix and bupropion in patients with mental health illnesses. If you have somebody with moderate to severe mental health, you should probably contact their mental health provider before prescribing them anything. And these patients will also probably need longer course of treatment. When your patient comes in and you're asking them if they're still smoking, if they are, ask them why. Are they taking their medications? Are they using them appropriately? You can increase the dose. You can essentially double the dose, and these medications can be given for a year. You can also try nortriptyline and nicotine replacement therapies as well. If they don't want to quit, keep offering it. Offer it at every visit and keep assessing them with every appointment. Thank you.
Good morning. I'm Terry Melvin, and I work at Partners in Care, which is a primary care practice, and we approach our patients by trying to educate them on their disease and empower them to make healthy lifestyle changes. And we do it again and again and again and again. With lifestyle modifications, when someone comes in to see their practitioner, usually it is in some type of a crisis. And we try to establish that there's a partnership, and the short-term goal being addressing what they initially came for, and educating them on how we would get through that initial crisis. And it could be anything. It could be a panic attack. It could be blood pressure not controlled. It could be something that they just don't feel good about, but they don't know what it is. Once we get through that, we then do sort of a long-term plan. What is the patient's goal? What is your goal? Is your goal to live long, active, independent, or to live the best life that you can
with the chronic illness that you can, which Peter Attia calls lifespan, meaning that they've stopped living many years before they die. And we try to reverse or improve the chronic illness to the best and prevent any further decline. But what we see happen, people come in so sick that we get over one crisis, and before we can even come up with this that we just talked about, there's another crisis. And the goal is for us to try to stop and break that cycle. I am seeing more people that come in now that come in proactively. They don't have any problems. They just want to establish and then have more of a healthy lifestyle moving forward. You guys are so lucky because when I started putting this together, I had just finished reading the book Outlive by Peter Attia, and I've read it 3 times since. And I really like it because it gives a kind of a foundation of where we have come from and where we probably need to go for good, healthy living. And he calls Medicine 1.0, it is guesswork. He did believe, there was this belief that disease was caused from nature and not by an act of God. But there was really no clear understanding of science. Medicine 2.0, or the germ theory, we here developed antibiotics, vaccines, and this is in the early 1900s. So, you know, we've come a long way and we haven't come a long way. Louis Pasteur developed the vaccine for smallpox and rabies. Joseph Lister was the first to develop that concept of antiseptic in the operation room, and then we had Robert Koch, who discovered anthrax and tuberculosis. So in 2.0, we saw that we went from this observation and guess to observation and framing a hypothesis, then testing the hypothesis, but we were still not preventing diseases. What we were doing was treating the illness, and then people were living longer, or that lifespan, with that illness. And we see this now. Patients with diabetes, patients that have had strokes, patients with cardiovascular disease, patients with chronic disease, chronic kidney disease, patients with central nervous system, MS, Alzheimer's, etc. So what does all this have to do with PAD? I think we are needing to bridge the PAD gap. And as primary care providers, we sometimes are still practicing medicine 2.0. Patients are still dying with amputations and critical limb ischemia. And these are pictures of patients that I've cared for in our practice. You know, so why is there a gap? Some of it is lack of education when we were coming through the system. Their primary care guidelines for PAD screening has been kind of unclear. And vascular surgeons has actually taken the lead to educate the primary care providers who see the patients first on what the importance is. That's why we're here today. And I want to thank Dr. Lassar for that. So who really should take the lead on this? There's a study out of Canada, and it says it should be a collaborative role between the practitioner, the provider, and the vascular surgeon and our podiatrist. These are our risk factors, really stressing the cholesterol, hypertension, diabetes, smoking, but even before some of those, people with elevated C-reactive proteins, fibrinogen, homocysteines level, and uric acids have been found to be at risk. We need to understand that peripheral artery disease is not a peripheral disease, it is a panvascular disease. It affects the brain, it affects the heart, it affects the GI mesenteric, so it's all over. If we see something in the leg, then we need to look upstream. So when you make the diagnosis, we can do it by toe pressure or brachial artery index. In examining the patient, we have to remove the socks. We have to look at the feet. We need to see what it looks like. Is there hair? Is the skin shiny? What is the temperature? Is there a pulse? Is there loss of sensation? 10 to 30% of the clients that we see will be asymptomatic. And we know that they start to have pain when the ABI is between 0.2 and 0.3. And we know that at 0.4, we start to have tissue loss. 50% of patients that don't have a pulse will be asymptomatic. Intermittent claudication, when I think back on my education, I think we spent one afternoon or a few hours on claudication, and the way they presented it was, you have the postman, he used to go 10 blocks, now he can only go 5 blocks, and now he's having trouble and he's having ischemia to the limb. Or muscle is crying for oxygen, or he's having angina of the leg. That's pretty straightforward. So I had a case of a 78-year-old lady. She presents to the office because she doesn't feel good, and she wants to be able to get up and start moving. Well, what doesn't feel good? Well, she wasn't sure. She just didn't feel good. Did the physical exam. We did an EKG, sent her to physical therapy, got a call from the therapist. She could not participate in the physical therapy because she started complaining of such severe pain. Where was the pain? She thought it was in her gluteal area. Bring her back in, we recheck her, and I'm ashamed to say, I don't remember if her pulses were present or not, but I bet if I went and looked at the chart, I could tell you. But we did some studies on her, and she had extensive atherosclerotic blockage. Stents replaced. She's cholesterol, cholesterols were addressed, on high statins, on anticoagulant, and today this lady is back to work part-time. The patients are not the best historian. Anytime I see a patient and they complain of something, and sometimes it doesn't make any sense, I write it down. Now, I may not be able to address this on that visit, but I write it down because I'll go back the next time when they come in and say, what happened with this particular symptom, to see if I can get that tied in. Lady comes in 3 months ago, and she tells me that she had a spider bite. I didn't write the spider bite down, but she said, she called back a few weeks later from that visit 3 months ago to say that she was having horrible pain. So bring her back in, we look at her, she also has disease, she's stented. I see her this week, she's doing fine, she's starting her walking program, but on the side with the spider bite, she says, that bite, which is no longer there, has given me some numbness on this side. On EKG, it's abnormal. We sent her in. She didn't tell me she had chest pain. She didn't tell me she was short of breath. When the nurse asked her and brought her in, how are things going, any changes, she said, they're all the same. And this was towards the end of the visit. She goes, I said, was there anything else we needed to address? She goes, what about that spider bite? I said, well, let me look at the spider bite. And you could barely see something there. And I said, so that looks like that's healing pretty good. She goes, well, what about all that numbness on that side that's causing me from that spider bite? So what we do is difficult. There's so many moving parts. So many moving parts. If we're in an office, we may only have 15 or 20 minutes to see the patient. And it's hard to pick up on what the issues are. But everything that they complain of, we put it down. So did we know that a GFR of 15, there's 2 times the risk of PAD? If someone is spilling albumin in their urine, there's 3 times the risk of PAD. The mortality associated with coronary artery disease and PAD is higher than just coronary artery disease alone. So in Medicine 2.0, people go in once a year, they'll have their checkup, they'll have a physical, they'll get blood work, they may ask about exercise, some stressors in their life, the BMI, they'll give them a list of things that they need to work on, and they probably won't be seen for another year. With the PAD script, we want to look at when someone comes in, what is their family history of heart disease, lower extremity claudication, or peripheral artery disease. We want to talk about smoking and really doing smoking cessation. To decrease smoking will limit a limb loss. Optimizing our statins, starting people on walking programs with resistance training, good foot exam, blood pressure control with ACE and ARBs, anticoagulants, and then collaborating with the podiatrist or vascular surgeon. Increasing the statins have been shown to decrease PAD, ischemic stroke, MI, and major amputation. And those are through the MACE, Voyager, and TIMI. So what I would propose is that in Medicine 3.0, and I know there's going to be this switch, that we start looking at what the coronary calcium index score is annually. What is the ankle brachial index? Have we looked at the carotids? Have we evaluated for metabolic syndrome? What are the fasting insulins? What kind of exercising are they doing? And it's not that we have an obesity epidemic, we have a muscle deficit problem. When I talk about exercising with my patients, a lot of times they don't have the resources or the ability to get out. We start off with something very simple. We sit to stand from the chair. We do step ups and step downs. We do non-resistance just with our arms, just to start off with. And so we try to meet them where they are, and then when they follow back up, we see how far they've gone. We do, with this lifestyle change, we want to start small. We start with the PAD script, and we kind of go down the line. The client needs to be accessible to us. We do this through our EMR and email, so that we will give them an assignment, and then we'll have them email us. We make a list. If we haven't received an email from them, we have a staff member that will call them. We ask them, are you a person that needs accountability? Do we need to follow back up with you? Are you somebody that's going to be motivated? 8 out of 10 times they go, I need some accountability. So then you will be sending me what your blood pressures are and what we've done in terms of your activities. In terms of diet, if you're drinking sodas, sometimes the first thing we do is no more sweet drinks. And then we're going to start focusing on the outside of the grocer and not so much down the inside aisles. We try to have little bitty wins, because with those little wins, they feel better, and then we'll expand it. But the key would be that ongoing communication. Thank you.
If the speakers could come to the front, Terry, you can just stay there. Go ahead and have a seat. Can I have the speakers coming up front, please? One of the genesis behind this section was to kind of look at some of the major problems that we have in this area. Terry, you said that you were in crisis management for a lot of your patients. When they come to see me, it's disaster management at that point, because usually something's falling off or something's in big trouble that we have to deal with. And so, one of the problems in the Tennessee area is that 25% of all adults don't have a primary care doctor. They don't have a leader of the captain of the ship to actually handle some of these problems. And so, I applaud the way that you address patients and how you talk to patients. Sandy, just enjoyed your talk very much. Is there any particular questions that you guys have for our speakers? Don't be shy. I know they're out there. Sandy, how we all have difficult patients, and it sounds like you have a good methodology to try to tackle some of those patients. And your clinical experience of 35 years, is awesome. Can you tell us, how do we get in contact with you, or how do we engage a patient with somebody that does what you do?
Great question. Ooh, that's hot. We are part of an accountable care organization, and the patients that we are allowed to help are based on the primary care provider for that patient for traditional Medicare or for Medicare Advantage. So those, let me just say the name of the clinic. Okay, so Memorial Employed Physicians are part of our network. Beacon providers are part of the network. Chattanooga Family Practice are part of that network. And then another physician down in Lafayette, Dr. Bowers. So when we started this program 10 years ago, we did include a lot of specialists. But again, our focus is on primary care. I think you said it real well. People are not always going to primary care. So they can select a primary care under the Medicare Advantage program, and that would give them the free access to our team, but they actually have to go. So part of our work, hi Dr. Melvin, part of our work is calling the patient up and saying, hey, you're supposed to be seeing your primary care and you haven't gone. Do you need transportation? What's the reason you haven't gone? So a lot of the care management work is behind the scenes. We're doing some things behind the scenes other than just coaching. But yes, this is a Memorial fully supported program. I don't think Park Ridge and Erlanger have anything like we have. Yeah. But again, we were trying to get ahead of value-based care and get ready for leaving fee-for-service and going to value-based care.
Yeah, and we need to. Obviously, we do, and I think that's great that you're having so much success in your role as that. The main things that Tennesseans tend to deal with, again, is access to their primary care doctor, whether it's voluntary or not. The other major issue is about 45% of Tennesseans would claim that they're in the obese category. So we do have a significant, weight issue and a high density of smoking. We've talked earlier about PAD. You saw all the pictures that Terry put up. And that's one of the first signs of vascular disease, of cardiovascular disease. So sometimes claudication, when they walk and have a problem, that may be the first sign that they actually have heart disease. They never knew. Smoking is a major problem for that. Laura, just real quick, what's the most successful way to actually convince somebody to stop smoking?
I like to use your line that we love smokers because we're always going to be doing surgery on them.
That's right.
We love smokers because we're always going to be doing surgery on them.
I tell them that. And then I tell them, I'm just kidding, I really want them to stop, so.
Yeah. You just talk the truth to them.
Yeah,
That's what I do.
they're very pragmatic people. And then weight management is also, a major issue that we're going to continue to fight here as well. I think we're seeing some, more medications now that actually be very effective for our patients. Is there any other specific questions before we take a break? We are running on time, so I'd like to let everybody just take a break for a few minutes. Please look at the vendors. We'll probably get kicked off here at 10:20, and I thank you for the speakers keeping us back on time.